That's it.
Yeah, there we go.
Okay. So we'll just leave it a moment while everybody enters the webinar, and then we'll go through the rules of engagement. Okay. Okay, so this webinar is being recorded. No one can see that you're attending unless you'd like to ask questions. So if you'd like anonymity during the question and answers, please tick the box to send anonymously before sending your question. We hope to make this webinar as helpful to you all as possible, so please do ask your questions. Type questions in the question and answer section, and please direct questions to panelists only, starting with the name of which panelist you are directing the question to. You may ask a question at any point, but they will be answered after all the talks. If we don't get through your questions in the allocated time, which is 1 hour, we will answer them via email after the session. Remember, this is our beloved South Africa, so if there are any signal issues and perhaps the video doesn't play well for you, it'll be available on our YouTube and Instagram channels after this broadcast. This evening's agenda, I will be doing a welcome, then it's Dr. Jack Biko from Femicare Fertility and Vice President of SASREG, who's going to be talking to us about endometriosis. Then Dr. Sulaiman Heylen from Cape Fertility and the President of SASREG is going to be talking about fibroids. Then Tansey Coetzee is going to be talking to us via video about her battle with endometriosis and her personal journey to motherhood. Then we'll be having a question and answer session. I'd like to thank our sponsors for this webinar, Ferring Pharmaceuticals. We appreciate your support and for helping us to bring these educational webinars to the public. Okay. Thank you to everyone for joining us on our first webinar for Reproductive Health Month. My name is Saskia Williams and I'm the founding director and CEO of IFASA. I'm proud to be bringing you the Reproductive Health Month campaign and webinars to you in association with the lovely ladies at House of Fertility, Michelle and Lucia, as well as the IVF Babel Africa team. We will be bringing you webinars every Tuesday and Thursday evening throughout February, featuring local and international specialists and speakers. So let's get started on tonight's lineup. Our first speaker is Dr. Jack Biko. Dr. Biko is a registered reproductive medicine specialist and a keen gynecologic endoscopic surgeon. He is from Femicare Fertility Clinic in Pretoria and is the Vice President of SASREG. He's going to be speaking to you now about endometriosis. Over to you, Dr. Biko.
Thank you for inviting me, Saskia.
It's a pleasure. Thank you for joining us.
Let me just share my screen. Good evening, ladies and gentlemen. I'm going to talk about endometriosis, which is a very, very important topic, and it has always been a very important topic. Well, it is a chronic menstrual cycle-related inflammatory disease. And the most important thing here is that it is an inflammatory disease. So what you see in the pelvis is just part of the disease. Some other parts of the disease are somewhere else. This is a complex systemic disease with diffuse manifestations, including chronic fatigue and various neurological manifestations.
Dr. Biko, your screen isn't shared.
Should be shared. Can we just do this? Is it shared now? Okay, there we are.
Now it's sharing, yeah.
All right. So, is that okay?
Perfect. Yeah, perfect. Thank you.
Yeah. So like I said, it's an inflammatory disease. It is a systemic disease. Therefore, surgery will treat the visible lesions and relieve some pain, but it does not treat the micrometastases or all the systemic effects. We cannot cut out the inflammation. We can cut out the disease. So we all know that endometriosis is a major cause of chronic pelvic pain. And the problem is this: there is a delay in the diagnosis, and this delay is up to 10 years. Now, during those 10 years of delay, patients are often misdiagnosed, and because they got the wrong diagnosis, they will get the wrong treatment. So they have 10 years of hit and miss treatments. And what also happens during this 10 years is this delay results in the patients presenting with an advanced stage disease. So you presented 10 years early with stage 1. When we make the diagnosis, because of the delays, you are now in stage 3, stage 4 disease, which is a sad problem. The question is, why the delay? There are a number of reasons why there's a delay in the diagnosis. First of all, society has normalized the symptoms of endometriosis. Period pains are regarded as normal. I can tell you now that if period pains affect the school of a child or the sporting activities of a child, that child probably has endometriosis. It is not normal. Then there's a problem with the healthcare workers. We get inadequate training in as far as endometriosis is concerned. And the problem is that the doctors who are not properly trained then go and do a laparoscopy. But the problem is this: if you don't know endometriosis, you won't find it. So patients will have surgery after surgery, and they will hear that we found nothing, there is nothing. That's because we don't know what we're looking for. Endo comes in different forms. It could be red, it could be black, it could be white. There can be peritoneal implants. There could be clear lesions. And this is the patient that we actually saw was referred to us. She had 4 laparoscopies, and all the time the doctor said that there was nothing wrong with the patient. When we examine the patient, we know what to look for. We look where to look for, pick up the bowels, and we look at the patient, and she had all the signs of endometriosis. After 4 negative laparoscopies, it was clear this patient had white lesions, which the doctor doesn't know about. She has black lesions, she has atypical lesions, and she also had the red lesions. So you have to know what to look for to find it. So the signs and symptoms of endometriosis include chronic pelvic pain, period pains, pains during intercourse, and most importantly, and often forgotten, chronic fatigue. These patients might have bowel and urinary symptoms, and we now know that the incidence of migraines is higher in patients diagnosed with endometriosis compared to those who don't have endometriosis, because this is a truly systemic disease. On clinical examination, often the uterus is retroverted and fixed, and there are nodularities in the posterior fornix or the anterior fornix or the ligaments. So there are sequelae of endometriosis. What it does cause, it decreases the quality of life of the patients. There is an increased incidence of depression in our patients of endometriosis, and this will result in adverse effects on intimate relationships. Also will cause a limitation in the participation of daily activities as well as in social activities. Now, because of the chronic pain and the chronic fatigue, there is a loss of productivity and associated income. Often the patients have to stop working because they are forever in pain or they are forever fatigued. These patients are also predisposed or at risk of developing chronic medical conditions. And a lot of money is spent, as you know, on the healthcare of these patients because of the many misdiagnoses, the many mistreatments, and the many unnecessary surgeries that they have to undergo. So endometriosis is truly a disease from hell because it causes severe emotional pain, amongst other things. So there are a number of stages of endometriosis, stage 1 to stage 4. But what is important to note is that the amount of pain is not dictated by the stage of the disease. A patient might have stage 1 endometriosis and present with severe debilitating pain. Another patient might have stage 4 disease and have minimal pain. So the amount of pain that patients present with does not tell us what is the stage of the disease. So what is the epidemiology of the disease? Well, we know that the prevalence in the general population is about 10%. But in those patients with infertility, the prevalence is up to 60%. So what are the risk factors for endometriosis? Well, we know it's genetic factors. It is thought that patients with a low BMI are at increased risk. Smoking and alcohol use also is said to increase the risk of developing endometriosis. Remember, endo is an inflammatory disease, and smoking is a pro-inflammatory substance. It is also known that the chances of conception of patients with endometriosis is less than half of those patients who don't have endometriosis. And there are a number of reasons that affect the chances of these patients conceiving. And I will not go through these reasons because we don't have time to go through them. I'd rather spend a bit of time on the pain because pain is extremely important and people don't understand the pain. So why the pain? Well, pain is caused by a number of factors, including the production of growth factors, various chemicals that are activated by various cells in the body. Also, on a monthly basis, the patients, remember with endometriosis, you bleed internally on a monthly basis. Now, that bleeding has got direct and indirect effects, which lead to chronic pelvic pain. The nerves also get invaded by the endometriosis, and we get irritation of the nerves by the endometriosis. And there are special cells called the mast cells. These cells can degranulate. It's like the cells we see in patients with asthma. And they have shown that the incidence or the number of mast cells are much higher in those patients with severe period pains. And the rate of degranulation of these mast cells is higher in those patients who present with severe frequent period pains. So having said that, so what are the principles of treatment of these patients? Well, the American Society for Reproductive Medicine has made it very, very clear that endometriosis is a chronic disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. We cannot have patients who come for their surgery every year. It is poor practice. It is substandard practice. So endometriosis in young girls, well, we know that period pains are common in young girls, but they should not affect their daily activities. Once they affect their daily activities, it is no more primary dysmenorrhea. It becomes secondary dysmenorrhea, and we have to find a cause. And one of the commonest causes of pelvic pain in these young girls is actually endometriosis. And keep in mind that even in these young girls, this is a chronic disease with the potential to progress further into stage 3 and stage 4 disease. And the problem is with these girls is that when they do go for endometriosis surgery, for laparoscopy, the surgery often comes clear because the lesions are typically clear. And the doctors think that there's nothing wrong with this child. There's no endometriosis when there is actually extensive endometriosis. So the goals of treatment of these young girls is symptom relief, give them painkillers, and then prevent the progression of the disease and protect their future fertility. So we can give these girls anything we want to give them, but we should maintain those goals, those 3 principles: symptom relief, disease progression, and protect the future fertility of the young girls. So what are the available treatments that we can give the patients? Well, pain tablets, non-steroidals are first-line treatments. This will work well in those patients with primary dysmenorrhea. Also going to work well in girls with endometriosis. If it doesn't work well, then we add a second line like progestogens like Vasan. We can also use oral contraceptive pills like Yes or whatever you want to use. And if the Yes doesn't work well, the COPC doesn't work well, we can then remove the placebo pills and give them active pills throughout the month. What we can do is that instead of these girls having 13 periods a month, we can give them pills such that they've got their periods only 3 or 4 times a year. Then they've got period pains 3 or 4 times per year instead of having them every month for 13 months or 12 months of the year. It is okay sometimes to put in the Mirena in these girls. If you have to do it, you take the girl to theater and you put in a Mirena. Drugs like Zoladex are very effective in the treatment of endometriosis, but remember, if you stop them, the disease comes back. And if you do give drugs like GnRH analogs, we have to start the patients with what we call add-back therapy immediately, because these drugs can impair growth of the bone and cause later bone problems in these young patients. There's a new kid in the block. It's called Elagolix. It's a new drug meant for endometriosis. It is a GnRH antagonist. Now, studies have shown that given 200 milligrams twice daily, there is a 76% decline in the amount of period pains after 3 months, and then 75% after 6 months. It also works for non-menstrual pain, that chronic pelvic pain that's there almost every day. There's a decline of up to 62% if we use this drug. The other good thing about Elagolix is that it also reduces the incidence of chronic fatigue. It is one of the very few drugs that also manages chronic fatigue. It's a very good drug, which unfortunately is not yet available in South Africa. So surgery for endometriosis is not the first-line treatment. All right. When do we do surgery? When adequate medical management has failed, when the patients have got debilitating symptoms, and maybe when they've got infertility. Because if there's infertility, we can either do IVF or we can do surgery. Who can do the surgery? Stage 1 and stage 2, probably most gynecologists can do it. Stage 3 and stage 4, I would suggest that only advanced laparoscopic surgeons can do it, because this is a very, very risky procedure. It has complications. Now, I can tell you about our data at our clinic, Femicare Fertility Center. We presented our data in an international congress in India and in our national congress in Durban last year. In over 1,200 patients, we had a complication rate of less than 1% in those patients where the bowel is not involved. But once it's stage 4, stage 3 involvement, once the bowel is involved, the complication rate goes up to 4%. It's very significant. So not anybody can do the surgery. It is difficult and dangerous surgery. What type of surgery? We can do laparoscopy or laparotomy. We recommend laparoscopy because you can see that it is better surgery. As you go in, it's like you switch on the lights and you can see exactly what's happening inside. It's better looking, not horrible scars. The patients recover much better than laparotomy. The role of hysterectomy, please, ladies and gentlemen, the disease is mainly outside the uterus. Therefore, hysterectomy should not be regarded as the standard treatment of endometriosis. These are pictures of a patient sent to us after hysterectomy. She still had chronic pelvic pain. As you can see there in the bowel, there's deep, deep, deep endometriosis there, stuck to the bowel and the bladder. Once we moved the bladder away, we could see that there's partial bowel obstruction. The uterus was out, but she still had the pain. Big problem. My pain is not better after the surgery. Well, there's a good reason for that. And I told you in the beginning, it's an inflammatory disease. The inflammation causes tissue damage and nerve damage. And then we get a central desensitization whereby the patients now have decreased pain threshold. All right, and then the next thing that happens is they become very sensitive to touch. So when somebody touches me, for those patients, when they're touched, that touch is not touch, it's pain. And in that case, further surgery is not helpful because we cannot cut out the inflammation. We cannot cut out the nerves. The best thing to do here is to add treatment for neurogenic pain and get psychotherapy as well. Big problem is the expectations of our patients. Ladies and gentlemen, we cannot cure the endometriosis at this stage. When we operate you, we can make you better. So patients must expect to get better. But if you expect to be 100% better, you will be forever miserable. All the surgeries that you will undergo will be a failure. You need to expect between 50 and 75% to be better, like 50% by 75%. If you do that and you keep that in your mind, your surgery will mainly be a success. Quickly, time is over. Does it cause cancer? Yes. There's a 1% risk of cancer in patients with endometriosis. What does it mean? It means that if you get surgery, it must be completely removed. Otherwise, there's a risk of the cancer being there. And secondly, if you burn it, you might have a problem and burn the cancer. You can't burn cancer this way. There are better ways of burning cancer. So burning of lesions might be problematic if we say that there's a chance that there can be cancer. Childbirth, does it reduce the incidence of endometriosis? A group from Italy said that they found that if the delivery is vaginally, there's a significant reduction in the risk of further endometriosis. But if it's a cesarean delivery, there's no decreased risk. And that is because after vaginal delivery, the mouth of the womb is more open and there's less retrograde menstruation. I believe there's a situation. So in conclusion, there's an old way of doing things and there's a new way of doing things. The old way of doing endometriosis was get diagnosed, you get surgery, and then you get medical treatment, and then you get many, many operations. That's gone, old-fashioned. What we do now is we diagnose you. We don't need the laparoscopy to diagnose you. We make a diagnosis, we put the patients on medical treatment, and when they want to fall pregnant, we either do IVF or we do surgery, proper surgery, one surgery that counts. No more many surgeries. In conclusion, surgery is not the first line for endometriosis. Not all doctors can operate endometriosis. Not all gynecologists can operate endometriosis. Not all fertility specialists can operate endometriosis. It is okay, ladies and gentlemen, to ask your doctor's credential before she performs endosurgery on you. Always get a second opinion. Thank you.
Thank you, Dr. Biko. That was very informative. We do have some questions and we'll go through them at the end. Okay, our next speaker is Dr. Sulaiman Heylen. Dr. Heylen is a specialist in reproductive surgery and is the chairman of Cape Fertility Clinic, as well as the president of SASREG. He will be tackling the topic of fibroids.
Thanks, Saskia. And also thanks, Jack, for this very good talk, and I think also for a very important talk. We, as fertility doctors and as doctors who are interested in endometriosis, see a lot of problems with the treatment of endometriosis. And I think the first question here at this seminar only went up, and it was a question that asked, when should I go for my second laparoscopy after my first laparoscopy? And I see Dr. Biko getting irritated already, because that is actually the bad approach, and that's still the standard approach which a lot of doctors are doing. They're doing a lot of laparoscopies. And Dr. Biko has made it very clear that for endometriosis, in the majority of cases, only one laparoscopy is necessary. It should be done at the right time. Very important, the timing is important. And secondly, it should be done by the specialist, the right person, somebody who is a real interest in the treatment of endometriosis and does excision surgery and not just burns it away quickly. So it was very well done, Dr. Biko. Thank you very much for that.
Thank you.
Then, thanks to Saskia for inviting me, and also would like to say something nice about Saskia, because since Saskia is heading IFASA, IFASA has done a lot of good work, and I mean, these webinars are part of it, but the dealing with the medical age has also been very important in that. And for patient education, she has also been a major contributor here in South Africa. So I think it's a real pleasure to work with somebody like Saskia, who's doing a lot for the infertility community here in this country, mainly for the people for the women and the men who are suffering from infertility. I'm going to talk today about fibroids, and fibroids is more common than endometriosis, but it's also a lot less controversial than endometriosis. And fibroids are a very common disease. If you look at fibroids and you look at why women do have hysterectomies, then see that a fibroid is the most common reason why women have hysterectomies. That means a removal of uterus. Now, I'm not going to speak about hysterectomies because I'm a fertility doctor. So I'm going to speak about fibroids, what the symptoms are, and when, as fertility doctors, when they are important for us. So the first question, what is a fibroid? So if you have the uterus, then uterus has 3 layers. It's got the inner layer. We call it the lining of uterus, or sometimes also the endometrium in the doctor's name. Then we've got the muscle of uterus, which is the myometrium. And then we've got the outer layer, which is the peritoneal layer, which is the covering towards the abdomen. So a fibroid is a growth. It's a benign growth outgoing from the muscle of the uterus. So basically it's one cell of the muscle that's starting to proliferate and becomes a lot of cell and becomes then a big tumor. This in contrast to a polyp. A polyp is a growth from the lining, from the inside of the uterus. Sorry for that. That's my dad calling from Belgium. Sorry for that. So a polyp is a lining, is a growth from the lining of the uterus. So fibroids are a growth from the muscle of the uterus. How common are fibroids? Well, fibroids are very common. Around 25% of all women in the reproductive age group will have fibroids. But the older you become, the more common it is. So it's typically in the age group between 40 and 50. And it is also an estrogen-dependent tumor, the same as endometriosis. That means that after menopause, when there is a lack of estrogen, the fibroids tend to go away. And very important, fibroids are more common in African women. Sometimes it's called the curse of the African women. So we as fertility clinics in South Africa, and that is for Dr. Biko and for ourselves, the same thing. We see a lot of women coming from other African countries, that coming from West Africa, East Africa, Central Africa for fertility treatment. And nearly all of them have had multiple surgeries for fibroids before they come to us in South Africa. And then the next question is, what is the cause of fibroids? Well, there's a combination of genetic factors, because it's more common in certain population groups. That can be caused by something in the environment, or it can be by endocrine factors, by hormonal factors, because it's an estrogen-dependent disease. But the honest answer is we actually don't know. We don't know why some women do develop fibroids and other women don't develop fibroids. And some women develop very aggressive fibroids. That means they have multiple fibroids that are very often coming back and are recurring all the time. And that's a very common presentation here in South Africa, especially in African women. So if you look at fibroids, then for fibroids, the position matters. So in Cape Town, when you buy a house, then the estate agent says you must look at location, location, location. I don't know, it's in other parts of the country, but for fibroids, it's the same. The position, the location is very important. You can have fibroids, 3 types of fibroids, basically. You can have a fibroid that's growing on the inside of the uterus. You can have a fibroid that's growing in the middle of the uterus, in the muscle, and you can have a fibroid that's growing on the outside of the uterus. And the fibroids that are growing on the inside of the uterus are the fibroids that are the most important and can cause most symptoms. And the fibroids that are on the outside of the uterus, they are causing less problems and less symptoms, and the fibroids that are in the middle or somewhere in between. So for fibroids, not only how big they are, but also the exact location is very important. Now, how do they look like? Well, this is a patient who had multiple fibroids removed from the uterus. So all these little balls are small fibroids that are removed, that are all single benign growths, so it's not a cancer, from the muscle of the uterus. And this is an MRI scan. What you see here is the uterus, and you see all these little black things that are fibroids. So this is the inside of the uterus, the endometrium. This is the inside, the endometrium, and these are all the fibroids, and this is the normal muscle of the uterus. So you can see here how these fibroids are growing inside the muscle, but the inside of the uterus, the endometrium, is still quite unaffected. Do they cause infertility? Well, yes and no, and it depends on where they are and how big they are. So if a fibroid is on the inside of the uterus, if it's in the wrong position, it can cause implantation problems. If the fibroids are very large, that means if they are in the middle position in the muscle and are more than 5 centimeters, they can also cause infertility. Or if there are multiple fibroids, you can imagine the first picture that I show with a lady where we removed 20 fibroids from that, if you've got multiple fibroids of the uterus, that it can cause infertility because the whole uterus, the whole place where the baby must develop is abnormal. So, place, the position is important. This little small fibroid that is growing there on the inside of the uterus can really cause serious fertility problems and implantation problems, while a similar size fibroid which is growing on the outside of the uterus will cause no symptoms, it will cause no pain, it will cause no bleeding problems in the majority of the cases, and also it will not cause infertility. So a fibroid which is sitting on the outside will not need surgery, but even a small fibroid that's sitting on the inside will require surgery. And then if you got multiple fibroids of the uterus, and you can imagine for this person who's got a complete distortion of the uterus, that she will need to remove the fibroids of the uterus. So sometimes women ask the size of the fibroid, when must it be removed? Well, if you look at this fibroid here, this is an MRI scan. This is a fibroid which is on the outside of the uterus, which is more or less the same size as the uterus. So it's a fibroid which is the size of a fist, but it's far away from the place where the baby must grow. So in the majority of the cases, a fibroid like that will not cause infertility. It can sometimes cause other symptoms like pain or pressure on the bladder, but it does not cause infertility. However, this fibroid, which is exactly the same size, causes a complete distortion of the inside of the uterus and therefore can cause severe infertility. It also will cause, for the majority of the women, excessive menstrual bleeding and very often pain during her menstruation. So here we come directly to what are the other problems that fibroids can cause. Excessive menstrual bleeding. So fibroids are a very common cause for women in their 40s, in their late 30s, 40s, up to the age of menopause for excessive menstrual bleeding. And typically, the menstruation is still regular. That means the periods are still 1 month, 28 days apart. And there is not always bleeding in between, but the bleeding itself, the period is very heavy. The flow is very heavy, and it can sometimes be prolonged. And therefore, it can sometimes, very often, it can lead to anemia, that women have got too much blood loss, and it can lead to a lack of blood in the circulation. Other symptoms are pelvic pain. It can cause chronic pelvic pain. It can cause pressure symptoms on other organs, typically on the bladder and in the bowel. And it can also cause painful periods. And these painful periods are typically when the fibroids are on the inside of uterus again. And you can imagine if there is a period, then there is a contraction of the uterus, and it feels like sometimes women describe it as labor pains, what they have. But it needs to be stressed that most fibroids do not cause symptoms. A lot of fibroids are there, and women come for a checkup and say, oh, there is a fibroid and there is another one, and they feel nothing. They have no infertility, they've got no excessive bleeding, and they've got no pelvic pain. So the majority of the symptoms do not cause the majority of fibroids do not cause any symptoms because they are not so big and because they are in a position that does not cause any problems. So, must you remove the fibroids? Well, I think we answered the question already, because most fibroids are not causing problems. And a fibroid is not a cancer. So we do not have to do surgery because we see a fibroid. We would be busy the whole day, I think, if we have to remove all fibroids that we diagnose. So we only have to do surgery for fibroids when there are symptoms, when there is infertility, and when it's a fibroid that causes that's in the wrong position, when there is excessive menstrual bleeding, or when there is pain. These are the indications for surgery. And even then, there are very often other options, especially for pain and bleeding. Medical treatment can be necessary. So then we can come to the question, can you give medication? Well, yes and no. We can give medication, but unfortunately, all the medication that is available in South Africa is symptomatic. That means it can control the symptoms, it can reduce the amount of bleeding. We go, for instance, like birth control pills. Birth control pills can give a reduction in menstrual blood by 50%, but it does not treat the fibroids. There is medication available in Europe which can reduce the size of the fibroids quite significantly, but is unfortunately not available in South Africa. So yes, we can give medication for fibroids, but we cannot really treat the fibroids themselves. We can only quite effectively treat the symptoms of fibroids. So how must we remove them? There are different types of surgery that we can do. We can do a laparotomy, we can do a laparoscopy, or we can do a hysteroscopy to remove them. What is a laparotomy? A laparotomy is what most women will call a bikini Caesar operation. So it's an incision like a cesarean section. And typically a woman has to be about 3 days in hospital, and recovery is 1 month to 6 weeks. The majority of the cases where this type of surgery is done when there are a lot of fibroids and they were big fibroids. For instance, if there are 20 fibroids, they're all 3, 4, 5, 6 centimeters, and other types of surgery will not be possible. Then we have got the laparoscopic approach, and the laparoscopic approach is becoming more and more the golden standard. What is a laparoscopy? You operate with small incisions. It's a minimal invasive surgery, and you operate on a TV screen. And very often it's a day case. That means the person can go home the same day or the next morning. And the recovery is much shorter. It's not 4 to 6 weeks, but 1 week to 10 days. Unfortunately, not all fibroids can be removed by laparoscopy, especially if they are very big and if there are multiple fibroids, because then it becomes technically quite difficult, and then the conventional surgery must be done. And then we have got a hysteroscopy. A hysteroscopy means that we put a camera to the vagina inside the uterus, and we can see the inside of the uterus. With this type of surgery, we can only remove the fibroids that are on the inside of the uterus. But you remember, these are the fibroids that are the important ones. So we can only remove the fibroids on the inside, not the ones on the outside. But the major advantage of doing the hysteroscopy is that it is a small operation. There are no incisions in the abdomen. It can be usually done as an outpatient setting. We can do it very often not in a hospital, but in a clinic, and the recovery is quick. It's 1 or 2 days. So it's a big difference, the hysteroscopic surgery. Unfortunately, for larger fibroids or fibroids that are growing in the muscle, a laparoscopy or laparotomy will be necessary. What are other options? The other option is called a uterine artery embolization. This is a small catheter that's placed in the groin, and it's done by a radiologist. He will advance a small catheter which goes through the blood vessels toward the uterus and then goes toward the fibroids, and basically the blood vessels are plugged so that there is no blood coming towards the fibroids anymore. And therefore the fibroids have no blood anymore and start shrinking. This is a good procedure that can be done, and it is more or less as invasive as a laparoscopy, but it's not always the first choice for infertile women, because it can sometimes lead to problems of the lining, can sometimes lead to problems of the ovaries, and the safety in pregnancy is not 100% clear. So this is usually reserved as a second-line treatment for women with lots of fibroids who are symptomatic, who do not desire to conceive anymore. But it's a very good option to treat fibroids also. So, in conclusion, fibroids are very common. They are benign growths. That means they are not a cancer. They can cause pain, they can cause bleeding, and they cause infertility. And fibroids must not be removed unless there is a good reason, there's a medical reason, and it's usually the patient herself who decides if a fibroid must be removed or not. And there are different options in the removal of the fibroids, but the minimal invasive approach is usually best. That means the laparoscopy or the hysteroscopy is best because the recovery is faster and it's also better for subsequent fertility. And I would like to end on a positive note that most women who are diagnosed with fibroids can have babies, and most women who have fibroids do not require treatment and can have normal pregnancies with the fibroids there and have normal babies afterwards. Thank you very much, Saskia.
Thank you, Dr. Heylen, and thank you for your kind words. You, Dr. Biko, and I make a good team when it comes to tackling the medical aids, and I'm sure we will accomplish even more this year than we did last year. Fingers crossed.
Let's hope so, Saskia. Yeah.
Definitely. Okay, great. Our final speaker joining us via video is Tansey Coetzee. She was Miss South Africa in 2007. She is a model, a businesswoman, and a mom to her endomiracle Peyton. She's available to connect with on Instagram at Tansey Coetzee. Now, if this video doesn't play well for you, it'll be available on our YouTube channel and Instagram tomorrow. And the doctor's Q&A session will start after this video. Okay.
Hi everyone! Thank you to the Infertility Awareness Association of South Africa for asking me to come and share my journey with you all during Reproductive Health Month. I am Tansey Coetzee. I am a former Miss South Africa, a businesswoman, a model, a designer, and an endometriosis warrior, to name a few. But my favorite title is definitely being a mom to my miracle little girl. My journey to motherhood started around 2016 when I was diagnosed with stage 4 endometriosis. I had been suffering in silence for many years, not knowing I had endo. I had been undiagnosed for a good 16 years plus. Growing up, I remember my dad would have to fetch me from the sick room at school at least once a month because I was in so much pain, and I even passed out in a matric exam once and had to rewrite the paper. I remember one time during my ballet exam, I blacked out and I had to get up, have some glucose, pull myself together, and continue dancing. I ended up getting a distinction for that exam, but anyway, these were all signs that I had endometriosis. But because we were not aware of this chronic condition, which 1 in 10 women suffer with between the ages of 15 and 49 years old, we just thought that all the suffering was due to the fact that I was anemic. My symptoms included vomiting, nausea, stomach cramps, blackouts, migraines, turning pale in color, lower back pain, body aches, hot flushes, and heavy periods that would sometimes last half a month long. My diagnosis was extremely emotional. I cried and I asked God, why me? What did I do to deserve this? And my gynecologist, Dr. Andre van der Westhuizen from Morningside Mediclinic, who actually diagnosed me with stage 4 endometriosis and a rare case of a bladder nodule after doing a laparoscopy, said this to me: "Honey, you are a Miss South Africa. This just makes you so real, so human, and more relatable, because now you have the platform to be the voice for so many women. You can help break the silence and bring awareness." And that was exactly what I needed to hear at the time. It was so profound. It helped me turn my pain into purpose. And that is why I'm here today, to share, to learn, to encourage, and to bring hope. You need to know that what you are dealing with is nothing to be ashamed or embarrassed about. You do not need to suffer in silence. There are so many experts and professionals who are willing to help us through our bad and our good days. There are chat groups to share our stories with each other. There are doctors to help alleviate pain and guide us through step by step. There are prayer warriors and endo warriors and groups and associations like IFASA who hold webinars and events like these to help create awareness and educate us and shed light on the subject. I want to share a little bit more about my personal endo experience before I leave you with the experts. So falling pregnant after being diagnosed with endo was an emotional roller coaster ride. I did artificial insemination twice, and both times it was unsuccessful, which comes with a lot of disappointment. And I wasn't quite sure how I would heal from it until I got baptized. And then I realized healing is both spiritual and emotional, and it makes you stronger spiritually and physically. Then my mom recommended I go to VitaLab, and I was introduced to Dr. Chris Fenter, and he suggested I do IVF treatments. The whole experience was pretty daunting, especially because I am petrified of needles, but I just knew I was in good hands. I fell pregnant from the very first IVF attempt. My pregnancy was great, except for a little bit of nausea, which subsided once I was cleared to stop treatment after the first trimester. But thankfully, there were no complications throughout my pregnancy. My doctors advised I do a planned C-section because of the severity of my endometriosis, and with a bladder nodule, they didn't think I would be able to push the baby out. And even though I really, really wanted to give birth naturally, I listened to my doctors, and thank God I did, because my delivery was so complicated. I would have had to have an emergency C-section in any case, because my endo was so bad. It took 3 doctors to get my daughter out, who was stuck behind all of my endo. My daughter is healthy, smart, and so beautiful. She's the most polite and well-mannered 2-year-old I know. And she's honestly the type of kid that every parent dreams of having. I put my body through a lot, but it was so worth it once I got to hold her in my arms for the first time. And every day is such a privilege to be her mom. Moving forward, currently my endometriosis is still there, but I am now better equipped to deal with the pain and more knowledgeable. I breastfed Peyton for 2 years, and I was on Microval during that time. Now I am on Vasan, and I deal with my pain using natural remedies. My homeopath, Dr. Pillay, has managed to balance my hormones with holistic healing, changing my diet, using acupuncture, and taking natural remedies and necessary supplements and vitamins. Just recently, I was also introduced to doTERRA essential oils by Renata Verwey, and it's been life-changing. I use these oils on myself and my daughter, and the results are incredible. These natural oils help with anything and everything from inflammation to migraines to skincare to mood changes. I also train between 4 to 6 days a week to stay fit and healthy. And now I am focused on living a healthier, active lifestyle And I have become more mindful of the things I put into my body. I want to have more kids, and God willing, I would really like to fall pregnant naturally. It is possible. And now, instead of asking, why me? I'm saying, I can and I will, because once you choose hope, anything is possible. I want to end off with this quote, which goes like this. The difficulties you face in life do not come to destroy you, but to show you what you are made of and just how strong you are. Thank you so much for having me today. Sending you all good health, love, and light. Stay safe, everybody. God bless.
Well, I hope that played well for you, because it's such a wonderful video and she's been through a lot. And I know she's watching the webinar today. So if you want to connect with her, please go to Instagram at Tansey Coetzee, and she's very happy to help you and answer questions of what she went through. Okay, we've got a few questions. Dr. Heylen, you answered one of them. So I'm going to start from second one. Okay, Dr. Biko, you mentioned 4 types of endo. I don't actually know what that means. How do you see the clear endo? Does that make sense to you?
Yeah.
Okay.
Look, it's how it looks like. It's experience. You need to be experienced to know when it's clear, and it's very shiny. It's a very shiny. So you look at the surface of the peritoneum, it's very, very shiny. It's like shiny. Sometimes it's like little cystic endometriosis. So you need to be experienced to see it. And it's common in the young kids. That's why it gets missed in these young girls.
Okay, great. And can you get endo when you're pregnant?
No, you don't get new endometriosis when you're pregnant. You don't get new endo. But the old endo can get complications during pregnancy. The cyst or the endometrium might rupture during pregnancy. The nodule on the bowel might perforate, so you don't get new endometriosis, but the existing one might complicate.
Okay. And is it still necessary to do surgery before starting IVF?
Not necessary. You can go for IVF or go for surgery. So doing surgery before IVF will not improve your outcome. You do IVF or you do surgery.
Okay. And then Dr. Heylen, currently, this is a fibroid question as well as endo. So currently they have stage 4 endo, and last week this fertility specialist found a stage 3 fibroid. Is this related to endo in any way? Currently, I'm 31 years old and undergoing IVF. Will it be advisable to continue with IVF due to the fibroid?
Yeah, so fibroids and endometriosis are a different disease. They are not related. But then the stage 3 fibroid, I mean, I don't know exactly what she means with stage 3 fibroid. Is what I said from my presentation. The size and especially the location of the fibroid will determine if it must be removed. So it's a fibroid which is sitting on the inside of uterus, in the place where the baby must develop, then it must certainly be removed, because if you put an embryo there, it's not going to work. However, if it's more on the outside of uterus, it doesn't matter. You can safely do IVF with a fibroid which is on the outside of the uterus without any problems.
Okay. And then I think this will be to either of you. What if I've been through so many different contraceptives? I'm currently on Depo-Provera, and now for the past year, my bowels are killing me. I need to sleep, I can't sit, and I'm in excruciating pain. Despite this, doctors are not accepting my request for surgery. What can I do?
Yeah, she needs to look for a second opinion. I mean, it looks like she's got this problem of pelvic endometriosis. So she must be examined by somebody with a special interest in endometriosis, and she can come to us, to Jack, or to other people. In Durban, there are also people. So if you give them our email address, that we can refer to people in KZN who will be able to look at her and see if she's got pelvic endometriosis, and then help her.
Perfect. Okay, evening doctors. I'm 29 years old. I'm currently on Zoladex. I want clarity on how long I can go on with it, considering the side effects it comes with. Thus far, bone pain, headaches, and hot flushes.
Yeah, we spoke about back therapy. So whenever somebody's on Zoladex, they should be put on add-back therapy immediately, not wait for 6 months or whatever number of years. So I'd recommend that she goes back to a gynecologist or the doctor who put on Zoladex to add what we call add-back therapy. Because if you don't do that, you're going to have bone problems. You always got hot flushes and stuff like that, because you need a bit of add-back therapy.
Okay. Can birth control pills, or can the birth control pill cause infection? It's my first month on the pill and I already have cramps on my left ovaries.
No, it doesn't cause infection. It doesn't cause infection.
Okay.
And it shouldn't cause pain in the ovary. What happens is the oral contraceptive pills, they actually prevent ovulation. So those patients with ovulation pain should actually get better. So new onset mid-cycle pain shouldn't really happen with birth control pills unless if she's taking something else.
Okay. How does endometriosis affect AMH levels and why? I'm 29 years old and was diagnosed with stage 4 endo in 2019. After 2 surgeries, now I'm told that my AMH level is 0.6, which means I can't have a child.
Yeah,
How does one, yeah?
So because an AMH level, it's a measurement of the ovarian reserve. And I think people always focus on a number. Huh? It's so much or so much. That's not what's important. It's important what it measures is the amount of eggs. It measures how many eggs are still left in the basket. So I always say to a woman, you're born with a certain amount of eggs. You must visualize it as an amount of eggs in a basket and it gets less every month. There's nothing what we can do about it to make it more. So it's not the medication that makes the AMH less. Even if you take long-term medication, sometimes the AMH, the number is less, the ovarian reserve is still the same. Okay, so you must not focus on the number always. The problem for her is that the endometriosis and the surgery for the endometriosis can cause a reduction in the ovarian reserve. So if there is done inappropriate surgery, a lot of the ovary can be cut away and she's got a low ovarian reserve. So now she says she's got an AMH of 0.6, which means I can't have a child. That's not true. Huh? So the AMH of 0.6 means that there are not a lot of eggs, but it doesn't mean anything about the quality of the eggs. And because she's 29, her eggs are probably good. That means if she does IVF, she will not have a lot of eggs, but we will take out a few eggs of good quality and she will have a decent chance of success with IVF. So I think she still has got a good chance of success with IVF.
Okay. And then she wants to know, how does one go about looking for the right doctor for stages 3 and 4 endo? What should we be looking for in the doctor's profile?
First of all, she must stop having surgeries. She must make babies. Because like Sulaiman said, that every surgery you do is going to damage your eggs further, ovaries further. So for now, a big thing should be to fall pregnant and surgery maybe later. For now, no surgery, just get pregnant.
Perfect, thank you. It's time to wrap up. So if we haven't got to your question, please email it to me, Saskia, SASKIA, @ifasa.co.za, and I'll forward it on to the doctor for their response. Okay, that's it. Thanks everybody for joining us, our first webinar.
Thanks for having me.
Yeah, it's a pleasure for having us on this.
Thank you guys. And on Thursday, we'll be online again at 6 o'clock covering PCOS. So you can register at www.reproductivehealthmonth.co.za. So thank you to the doctors, Dr. Biko, Dr. Heylen, and also to Tansey for joining us tonight and for imparting your knowledge, and for Tansey for giving her personal story and being so open and honest. And thank you to Fairing for sponsoring our webinar today. Thanks, Dr. Biko. Thanks, Dr. Heylen. Keep safe, everyone.
Bye-bye.
Bye.
Bye.